All right, welcome everyone to the DRC Surge Capacity Focus Area session, our September session. We are one full year officially into the Disaster Response Collaborative. So thank you for sticking with us and doing all the work we've seen some great work so far with the tabletop exercises as we move into the drills. Again, another great session for you today, hopefully. So we are going to be planning for staff during surge events. We've got a panel of wonderful speakers. Before we get started, please know that the Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. The content presented today is that of the authors and does not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. Our learner notification, we will be offering continuing education and continuing medical education credits for this session. At the bottom of the screen, you can see the requirements to claim these CEs. You're going to need to attend the entire live session. Ensure you complete the session evaluation at the end of the slides today. And then make sure your name is on the session registration. So if you are using someone else's registration and their name is over here in the participants list, go ahead and on your little box where your name is, make sure you rename yourself. And then also at the end of this session, we'll have the slide with the instructions on how to go in and claim those CEs. Again, we are very happy to have you join us today. We're really excited. We've got a great session. We will record this session. Always like to double check here. We are recording the session, and the slides as well as that recording will be posted on the website probably later this week, early next week. Any questions you have, feel free to throw those in the chat or the Q&A. Again, we are offering CMEs and CEs. The DRC as a whole will be offering MOC Part 4 credits. And then your current DRC priorities, just keep in mind, we are still accepting that TTX data collection survey. If you haven't completed that, you still have time to do that. If you need the link to your hospital's TTX data collection survey, you can always email me at dncppn@austin.utexas.edu, and I can get you that link. And then also planning your hospital's drill coming in the next few months. Go ahead and start planning that and getting that on everybody's calendars and deciding who needs to be there for that drill so that they can be present. Okay, and with that, I will hand it over to Dr. Hussein. Thanks, everybody.
Hi, everybody. Really great to have you here today. Just knowing that this has been, a long weekend that we're coming out of. There's a lot that's happened this past weekend, and even going into last week. It's been a pretty crazy month to say, but the past few days have been pretty eventful, and wanted to, if it's okay, wanted to take just a pause to recognize the everybody that was involved and victims of the mass shooting that happened in Minnesota, in Minneapolis. All three hospitals, that the staff that cared for the children, the families of the children, all of the children injured and the ones that passed away. So we're going to just take about 30 seconds and just give them a pause to remember them and understand their trauma and difficulties. Thank you, everybody, for that. We have a slightly different session today. We wanted to go coming out, again out of a long weekend with a panel. We've got some great speakers today who are going to be discussing how they surge their staff in situations where their staff needed more capabilities or more capacity for each of the staff. And they're slightly different situations. So really looking forward to hearing from all of everybody. The objectives here are, as you can see, are talking about a staff shortage, increasing the capability or capacity of staff, and how to repurpose staff in creative ways. What we plan on doing is going through each of the speakers, and then at the end of that, want to open it up to our larger group for everyone to go ahead and ask questions. You can put them in the chat as we go along, and then we'll scroll through those and also call on people who have put comments into the questions and comments in the comment section as well. But please also at the end of this, please share your experiences as well. Next slide. One more. So really excited to have our three panelists today. We have Carl Erickson, Dr. Carl Erickson, who is from Oregon's Health and Science University Children's Hospital. We have Mason Yarba, who is from Stanford Medical Children's Health, and Dr. Larry Kosolik, who I am sorry, I stare at for hours, but who's amazing and awesome too, and really excited to hear about his how he managed staffing during their prolonged downtime. So we are going to start, if you guys are okay, I'm gonna start with Larry because I just need to move some questions around. And Larry, if you could just kind of just start us off and describe how and why there was a need during this prolonged downtime to increase your staffing, and what staff roles specifically were you needing to increase the capability and capacity for during your situation? And if you want to give people a background, however you feel necessary on that, please do.
And so thank you for having me. So I'm Larry Kosiolik. I'm a little bit perhaps of a unicorn in this field. I'm an infectious diseases physician who oversaw our COVID response, and following that, we consolidated our pandemic special pathogens program with our emergency management program to have a single all hazard preparedness response. And so I was also one of our leaders for a cyber security incident that we had in 2024, is February of 2024, where we were essentially offline for about 28 days. And so quite stressful. And so I think until you lose access to certain systems, you don't realize how dependent an organization is on technology. And certainly I think we could all understand the role of the electronic medical record, for example, or internet activity or a network, things like that. But what we don't realize or think about or take for granted is some of the very simple things that machines do for us. So things like print labels, things like maintain a medication administration record, things like controlling secure access and monitoring access to medications, including narcotics and other highly regulated substances, calculating patient weights and identifying issues in the chart, things like that. And so all of these things that our hospital relies on in terms of technology, many of them were down. And so if you're running a pharmacy, for example, the machines would determine the weight and ensure that that's correct. It would monitor dosages that are prescribed and advise the pharmacist if those dosages are correct and safe. It would print labels, etc. And so like our pharmacy went from needing people to be doing very simple and straightforward types of tasks like double checking weights and double checking dosages to make sure they are safe, handwriting labels to begin with, for example, and making sure that's done legibly. Our laboratory would need people to, rather than have results that are just automatically uploaded into a system, would need people to physically print results and store it in a physical location that's organized that providers can reference, either being organizational folder, for example, for outpatient labs, or patients charts for inpatient. It would have to be available to answer questions by phone that normally the lab wouldn't have to answer, because reports and reference ranges and things would be very well spelled out in the medical record. And so if you start thinking like that and go across your organization, you can imagine that a job that would take 1 or 2 people now may take 8 or 10 or 12. And so we relied on the leaders in those organizations to define the specific tasks that were needed, and then help advise our incident command structure on the types of skills that were needed and the number of people that were needed. And so our planning chief, who is our chief people officer, was responsible for that part of our incident command structure, and coordinated a labor pool where we would identify staff that we can deploy from some areas to others. And we were able to do so based on the skill set that they had previously. For example, if we had people with some sort of clinical experience or nursing experience, they would be better served in a role that wasn't calculating weights or wasn't writing labels. It was rather them perhaps fielding calls about clinically related activities that they had some background and experience in. What I think the most important aspect of our response that helped us ensure that we had the correct number of individuals, that the individual responsibilities were appropriate, and that the prioritization of those staffing and roles was appropriate, was by having our Center for Quality and Safety deploy our improvement consultants to our highest need operational areas that needed real-time process improvement. And so they were able to apply real-time PDSA cycles, sometimes multiple over the course of a day or a week, to identify perform a gap analysis and identify key areas that required an intervention, and then be able to follow that over the course of the next several days to weeks, to ensure that what we were intervening upon was done appropriately. And so I think having them as a sort of an unbiased and well-trained group in the process improvement pathway allowed us to have some objective analysis of that, rather than taking solely the feedback from a very, very stressed out director, senior director of a clinical area, whose job it was to ask for as much as they can to offload a stressed workforce. So having that balance, I think, and objectivity was really helpful in our response.
That was a great use of a resource that, that might not typically do that work, and putting them into a task that is adjacent to their field. Were there any other staff roles that you were able to, task shift to fill other roles?
So I think some of the most versatile staff on at least from a clinical level, if we're thinking about clinical care, because the other thing is that clinical care, we can normally get away with the ICU sometimes with a 2-to-1 nursing ratio, and particularly for lower acuity kids, or 4-to-1 on a general floor. When nurses now have a lot more manual work to do in terms of running pumps, and a lot more steps and unusual steps in terms of documentation, in terms of obtaining and tracking medications that have been given, the extra work that it would take to actually get a hold of a clinician to come to the bedside, we upstaffed our clinical teams as well, where a patient who was perhaps 1-to-1 in the ICU would now be 2 nurses for one patient, et cetera. And so I think where we have a ton of versatility in our workforce for those clinically related roles are with hospital-based medicine and advanced practice providers. And so hospital-based medicine, they're trained in general pediatrics. A lot of them have really intense and high level training in complex patient populations, like in the NICU or the PICU or the emergency department, for example, urgent care. Our advanced practice providers, we have a very large group. You have to remember that they typically don't do residencies or fellowships, so they're not focused on one area. So they have a very general and broad-based education, and many of them will jump from field to field over the course of their career. And so they tend to be very adaptable and have a lot of deep clinical operational knowledge and know-how. And so those teams were good for staffing call centers, for example, for being able to be deployed to the emergency department, for example, where volumes are oftentimes unpredictable, and where an existing triage structure is already applied, where we can assign individuals with less practical experience in the ED to lower acuity patients that more aligns with general pediatrics, for example. And so I think we found a lot of value from those types of individuals.
And then just from my list of questions before we go through all the panelists, were you pulling any staff members, clinical and non-clinical, from other areas, not within the hospital, but within the system or outside of the system? And how did that look before and then during the process?
Yeah, so we are a freestanding children's hospital. We're not part of a system. And so we don't have a really deep workforce that would allow us to move from other hospitals. Like we don't have adult trained providers that would be able to cross cover. We do have other organizations that, like in an emergency, if we needed to have emergency privileges or something, we would, but this was not that type of situation. We do have, I mean, there's a ton of bedside nurses, and this is probably the case everywhere, really. But I mean, I think a very common professional development pathway in medicine, at least at our hospital, is bedside nurses will oftentimes promote on leadership pathways or move into other roles in the clinical support roles, such as infection prevention and control, for example, or even emergency management. And so while we did not typically like redeploy them from some of these support roles, we definitely did not expect nursing leaders to all of a sudden return to the bedside, because the leaders were really incredibly important for putting out fires and maintaining staff morale and things like that. We did improve and increase the amount of rounding that these individuals would do to be able to assist and identify things that they could help with in a support role. But we wouldn't, like, for example, assign an emergency management manager who was a nurse 10 years ago to all of a sudden, be a bedside nurse. But they would support as reasonably as they could.
And I know that all of you are having questions pop up as you're hearing all of this, so please feel free to put them in the chat now, and then we will get to them after we get through our panelists.
I think more common was, and this helped during COVID, right? Is having a really deep, good understanding of who doesn't actually need to be on site, and who can work from home when needed, what resources they would need. I think a lot of that's usually part of like a business continuity plan for the hospital. And with COVID, I think a lot of teams had transitioned to nearly full remote capacity and had been in the progress of slowly returning. And so having an understanding of who and how can work from home to free up resources within the medical center, such as printers and laptops and other sort of more mobile resources that can be deployed. We had to do all manual printing, for example. And so if we know that a group can transition to home and doesn't need their computer or their laptops or their printers in that physical office space, that leaves resources to be able to be deployed to clinical areas and clinical support areas where printing needs had increased.
Oh, that's interesting. Might not be redeploying the staff, but they're not functional in their typical context of using their equipment and supplies. I'm just gonna, we have Erica who commented, who also was dealing with the same disaster, and she said, and Erica, feel free to come off and add to this. One additional method of pool expansion specified to the ED in this scenario was to call in all ED physicians on backup. So there's a backup system within your hospital to call in the backup. So it's one additional person for the first 3 weeks. And Erica, if you have anything that you want to add to that.
No, I think that Larry discussed it really well. The other thing, just to make note of, was that for our research assistants and clinical research coordinators whose research had paused due to the downtime, they were a really critical group to redeploy as well. So for the first week or so, we had them working, actually like writing out labels and collating disaster charts. So they increased our disaster chart supply very rapidly. And then as the downtime progressed, they were redeployed to other areas as well in non-clinical roles so that they could continue to report to work, to have their hours, even when their research was paused.
That's
Yeah,
great.
and to Dr. Lazan's point here, I think visibility and rounding was really important. I think, ironically, with the feedback that we got after about a week of doing that was, you're distracting now. Like, you're so visible that we can't get our work done. And what was happening, you have this large leadership structure. So our CMO would be there, and then an hour later the COO would be there, and then the CNO would be there. And it's like, we don't need to talk to all three of you. And so we ended up having to coordinate and assign, like, okay, you're the leader for this unit, you're the leader for this unit, and get feedback about, like, when are we becoming not helpful anymore, and please be honest with us, because they were so stressed out, they don't want to just take time to again explain to another leader why they need another printer or why they need another person here to help them.
That's a great insight, Larry. It's like having, a VIP from the administration come through your city and shutting down traffic for those hours.
Yeah, we've seen that too.
Okay, we're going to move on to the next speaker before we, and we'll go, Dr. Carl Erickson. You had a different situation where you were in the middle of a tridemic, and your physician leadership working with the nursing leadership need to increase the capacity of your nurses. Can you describe for us the situation and kind of how we can start with the nurse staffing limitations and how that impacted your surge response and what measures you took to address these limitations?
Yeah, thanks. Hi, everybody. Carl Erickson. I'm a pediatric intensivist at Dornbecker Children's Hospital in Portland, Oregon, which is an academic children's hospital affiliated with OHSU. In 2022, we had an RSV surge, much like the rest of the country, where we ended up increasing our PQ census by about 50%. We increased our acute care census by 20–30%, somewhere in there. And we also had patients with RSV in our NICU, which in some NICUs is heresy, and others is less uncommon. That was the first time we had done that in a while. And I think nurse staffing ended up probably taking up the bulk of the conversation within our planning meetings, both before we activated the EOC and in the EOC. We are in a state that has a very rigid staffing law, and we did a lot to try to work within that initially, including trying to get volunteers who were no longer working in the areas that were impacted. The area that was the most impacted was the PICU. And so we were looking for PICU nurses among nursing staff that were now working in ambulatory areas, that were now working in the PACU or in sedation services or other parts of the hospital. That was all on a voluntary basis. That helped some. But we were trying to go from a baseline staffing where we were staffing roughly 85% of beds to staffing every bed, and ideally being able to staff some surge areas as well. And that definitely did not get us all the way there. Keep in mind, this is it's an issue with not just the numbers, but it's also an issue of acuity. So the census was high, but because we were so strapped in the PICU, what that meant was that we were kind of pushing the problem out into other areas. So everybody in the PICU was intubated, which meant that we were starting non-invasive ventilation on acute care units, which is something that we normally don't do, which obviously then presents a completely separate issue on the acute care units potentially. We were taking care of patients with RSV in our NICU, which we don't usually do. And so I think this was both helpful and also presented challenges. It was helpful in that it allowed us to kind of spread the burden of patients across as many different areas as possible and bigger staffing pools in general. I think it was difficult in that we were doing things that we weren't normally doing. So the neonatologist, for example, would call us up and be like, hey, so how do you wean one of these kids with RSV who, you think is getting better? Because they're used to weaning kids who have, extreme prematurity. And this was kind of a different schedule. And the respiratory therapists were actually incredibly valuable in helping to sort of on a daily basis educate the neonatologist that actually you could probably move a little bit more quickly getting this kid off the ventilator. So that strategy, I think, definitely helped. What we ended up doing is we really couldn't change our staffing ratios without declaring a staffing crisis at an organizational level. And so that is what we ultimately did. We were communicating really closely with other health systems, including the other children's hospital in the area, the medium to large size children's hospital in the area. And so we declared a disaster, and then they did almost immediately afterwards. So I think that was really valuable because we felt like we were in it together as opposed to, different organizations doing different things. Once we had declared a disaster, for a staffing disaster, that allowed us then to staff differently. And this part was hard for me because when you think about surge, there's the conventional, then there's a contingency, and then there's a crisis. What we essentially did was we had to declare a crisis so that we could implement our contingency level. And so that felt goofy, but it also was what we needed to do in order to get the flexibility that we needed. So once we had the ability to change ratios, then we did. We tried to do that as little as possible and to be really thoughtful about how we were doing it. I really want to echo what Larry said about, it's pretty easy, I think it's, there are oftentimes calls for nursing leaders to go into staffing, but the nursing leaders were incredibly important in helping to organize the response and helping to make sure that people felt like they were safe, that people felt like they were supported, and that the entire response kind of didn't completely go off the rails. And they were working incredibly hard to do that. I don't think it would have been realistic for them to also be trying to provide care at the bedside. A few things that I found that were kind of interesting. We had a separate surge area that we really struggled to staff because staffing a separate area is almost never as efficient as staffing your primary areas. So we pretty quickly, and by that I mean like it's about 24 to 36 hours, developed a plan for cohorting multiple patients in one PICU room, which was not super pretty because we don't have huge PICU rooms. But the reason we did that was because it was a lot easier to add one patient to the footprint of the PICU than it was to try to open up a substantially separate area. And through the rest of the response, we did that much more. We cohorted patients in in rooms much more than we opened up the separate surge space. We had a system called Helping Hands where you would sort of staff a different area than you normally would, and you wouldn't necessarily be the primary person who was there, but you would sort of help. That helped some, but it was not quite as, it didn't really get at the primary issue, which was we just needed more ICU trained nurses. We did end up getting a statewide disaster declaration, which was really helpful. I don't think, and that was for pediatric RSV, just to be clear, it was not like a COVID related thing. Our state health authority CMO was a pediatrician at the time, which was amazing, and advocated really, really effectively with us, with the governor, for this declaration. And that's not the kind of thing that you can rely on, because it's, it's not going to be in our power. But I think that helped to sort of elevate this at the level of the state, which I think, felt good. I see a question about adding patients to a single room within the EMR. We have Epic, and Epic allows you to add a whole bunch of rooms. So you just add them, and we added them as surge beds or as overflow spaces so that they don't count in your denominator. They're just kind of there if you need them. And we had already done that a fair bit during the pandemic. This is where it was probably an advantage that we were a children's hospital within a larger health system, because we had a lot of experience doing that for COVID, both setting up new care areas or just increasing the size of a footprint. But it's actually not super complicated. It's informatics work, but especially if you've already done it once, it's not terrible. So we have a lot of spaces in our hospital that have 2 or 3 identities, depending on what we need them for. We have other areas where, normally there's just one patient in the room, but we have a second bed there, kind of as a ghost bed.
Yeah, and I want to echo what Marie and Lazan put in the comments. Marie, feel free to come off of mute. That you were lucky most states would not make a declaration, and I think many states tried. Could you give us some insight, Carl, into maybe some of the conversations that led to that point? Because I'm sure that didn't happen easily in your state either.
So Oregon has, together with Washington, the fewest beds per capita in the country. We also, on the West Coast, I think during COVID, we got a reputation for governors that were maybe following the science a little bit more clearly and relying on their public health leaders, as opposed to, being in the spotlight on one side or the other. I think those things probably helped a little bit. We have because of COVID, we had really strengthened the relationship between the different hospitals around the state. And we were meeting on a regular basis to sort of go through capacity related problems. And we were talking about skilled nursing facilities and all these other issues that, a lot of hospitals were facing through the pandemic. And I attend that as part of my health system's mission control leadership group. And we have a big role within this state in terms of helping to coordinate some of these placements. We have a medical operations coordination center. So we do a lot of things within the university hospital that are for the state. And it was a few of those calls where we had both our public health leaders and hospital leaders that I think really helped, including some impassioned pleas from people who were really torn up about the fact that we didn't have the capacity that we needed. So there were a couple kids early in the response that were sent out of state, and that really, really bothered people. We also, just as a slightly smaller state than others, I think there's always been this sense that we have to kind of stick together, and so it was a very coordinated response across a lot of the hospitals, and I think that helped to send a message to our public health leaders just how big a deal this was.
I really love that it speaks to kind of the regional approach to any of these disasters. It's not just one hospital on its own. Thank you for talking about the nursing, but could you also mention how you took care of the physician staffing limitations?
Yeah. So one thing I should say before I get into the physicians is that respiratory care was also extremely limiting. And that was a huge issue because we just don't have as deep a pool. So we were doing what we could on that front also. But that was actually, if anything, maybe more challenging than the nursing care because we just didn't have the numbers. So we tried, travelers, lots of other things, but obviously for a no notice event or a limited notice event, travelers, our lead time for travelers is 4 weeks probably at best. So physician staffing, there were a couple issues. We had essentially shut down our elective admissions. So anybody who wouldn't be hurt medically by a 4 to 6 week delay was pushed off. What that meant is that when we looked at the population of patients in the hospital during the surge, not only was it a lot of patients, but we had far more patients on a lot of our medical services than we normally do because our surgical services were not nearly as busy. And so our pediatric hospitalist team, they have a system where they have sort of an articulated, other team that will get employed to round during the day. They implemented that. We found that at night, the burden on the overnight covering team was just huge. So we brought to EOC a proposal that was accepted for funding a temporary overnight moonlighter position that we were able to get. We actually paid pretty well, which I think is why we were able to get that covered pretty well. And again, through the EOC, lots of stuff is possible. I think you just need to kind of be able to describe it in a way that's compelling. What people were most interested in was what were the criteria that were going to allow us to shut it down. So in other words, they didn't want to do this in perpetuity. They wanted to do this while there was a really clear need. Another thing we did that I actually thought was really fun was a pediatric surge physician. So this was sort of it's almost like a CMO emissary kind of person who's in the role for a 24-hour period, who would round on the acute care units, check in with the teams, both the nursing and provider teams, on safety issues, if there were questions about non-invasive ventilation or people had concerns about individual patients, et cetera. They also helped a lot in terms of triage, in terms of general problem solving. And I think this was really helpful because, as I mentioned before, we were doing things on the acute care units and in the NICU that we don't normally do. And so we heard a lot of positive response to that role. There were hospitalists, intensivists, and neonatologists in that role, all with kind of a systems lens. And that was another role that we got funded through EOC, and another role that they were happy to fund for a limited period of time.
Yeah, I think that you gave really good examples of how you can put in different systems. And then one last question, did you have to do any just-in-time training, and did that come up as you went along, or were you using the staff that you already had as experts to do that bedside education?
We were generally using the staff that there was not a lot of need for just-in-time training. There was a little bit, like when we were starting non-invasive on an acute care unit, for example, and the pediatric surge physician role was actually really helpful for that. We have a rapid response program, as just about every children's hospital does, and the rapid response nurses were also really helpful in terms of just ongoing education for the acute care staff. But I was struck by how hard it was to try to get someone to set up something, to work in a different area. That the approach that we ended up taking was, rather than, trying to get, this person to staff an area that they never staffed before, was try to figure out how we could distribute the patients in the most effective way. And then each area kind of worked on their surge response as effectively as possible. I don't know that that's the only answer, but within our organization, it was so hard to try to, get someone to show up to the PICU who's never taken care of an intubated patient to then suddenly be, comfortable trying to figure out, ventilator troubleshooting. Is the endotracheal tube in the wrong place? Is it dislodged, et cetera? It felt like that was just going to be too big a hurdle, and probably not ultimately as safe as, just stretching within the confines of what people more usually do.
Thank you so much, Carl, and really, just understanding that the willingness to respond also comes into the comfort level of people's how impactful they feel that they're trained in ability to work in that area. So thank you. Mason, thank you so much for being here. We're so excited to hear from your perspective as a nursing leadership on how you were able to, during the surge, also increase your capacity and just work on the capabilities of across your hospital.
Yeah, my name is Mason Barr, Director of Nursing Staff Resources, overseeing our float teams, administrative nursing supervisors, now vascular access. I've been fortunate to be part of response surge staffing for COVID, labor pool. I sit on our contingency planning team. Like Dr. Erickson, we are also a unionized hospital. And so there are hurdles, we'll call, sometimes to go around, and then working with OEM, and then, was asked to help with our RSV surge. And I think in large parts because we have multiple float teams, float pools, and we've always been asked to pop up units to take care of patients, to do things normal other units wouldn't do. And so we were asked to care for RSV patients on high flow, freeing up beds in the PICU, allowing for the higher acuity patients to be in the PICU. But this is an acuity level never, hardly seen on a unit for such a long period of time. And it just wasn't nursing staff alone. It was respiratory. We had a great partnership with our providers, great partnership with our nurse educators. And so what we did was we had one primary team of providers. These were the providers who went and saw the patients in the ED, who accepted them into our acute care areas, knowing they were pretty sick. We had a designated RT. And these are important. The success of that unit is because we just had one point of contact for that shift, right? One point of contact for our providers, like who's the provider on? Let's go talk to them. Let's talk about our concerns. It made escalations. It made coming to see the patient move so much faster. Same with our RT. There was one RT who was just on this floor. But in order to do that for the RT, we had to train other acute care nurses how to do some of the RT specific roles, treatments, MDIs. So it was really a big effort by all acute care areas. As part of the flow teams, we have critical care, we have oncology, we have NICU, and we have acute care. One thing we did was utilize our NICU nurses, right? Any kid or any patient who was under 6 months, our NICU nurses in the flow team, our neonatal flow team, they took care of our little kids. We also have what's called it's like a flex nurse. It's basically a buffer nurse for a hospital. We staff them with our critical care flow team, so then they can check on acute care. So then they could help with a kid decompensating, maybe ideas to prevent the kid from going to a rapid, to going back to or going to the PICU. And then our acute care nurses, we had our education team train them up. It was a quick training. Other ideas we use is our travelers. Like Dr. Erickson said, they 4 weeks, and we couldn't even find travelers we wanted. So we just needed to find anyone with pediatric experience, anyone we can train up to at least take care of the pediatric patient, as well as the parents. I think pediatrics, there's always the two cares that we have to provide to the parents and to the patient. So those are the things we use. I will say leadership was super important on that, just for visibility, right? As leaders, our role in nursing is to remove barriers so our staff can do things. So leaders, and float teams, we just normally float around, right? But we implemented a daily DMS in the morning and in the afternoon. Really made sure they knew who was on call to help with troubleshooting. But those are some of the things we did for our RSV search.
Yeah, and Nathan, you spoke to this a little bit, but just coming from your perspective, a culture that is hard to change, right? And if nurses, as one example, are not used to working in one area, getting them to do another task in another area, how did you kind of overcome that piece of it?
I think it was because of the lack of like prep time, lead time. I think we always ask our float team nurses to do things that they normally wouldn't do. So I think when the opportunity came up for them to work in an acute care setting, many of them, because once again, we couldn't tell them, right, this is out of their region in a unionized hospital. So it's all voluntary. But I think they saw the needs for the patients and then just being on the float team themselves. But I'm pretty sure it's more the need of the patient and how sick they saw the kids in the ICU, knowing that there's nowhere else for them to go. Our ICU beds are full, our ED is full. Really, the only place for them to go is in our acute care. How do we care for them in their acute care? How do we prep our nurses to be okay with them in the acute care?
And then were there any anything that you can tell us about just from a unionized hospital for work stoppage that you pre-plan for those events that you could give us insight to?
Yeah, we have many secrets we prepare for, but no, I think in 2022, we did have a work stoppage. So when we went through 2025, we put a couple lessons learned. I think the one hard part for us, 2025, there was no work stoppage, which is great. But what we learned is our ICUs really struggled. So how do we partner with our APPs, our nurse practitioners, to be part of the strategy? So in our ICUs, for example, it would be in a 1 to 2 assignment for our bedside nurse, but they would partner up with the APP, and the APP would be the ears and the eyes of the patient, right? They would say, hey, this is what's going on with this patient. I think for our ambulatory areas, we were going to look at maybe a call center model, right? How do we have all our nurses at one area to then be called triage out from a physician or from someone else at that ambulatory site, with leadership being involved at that call center area. So leadership can then help coach, teach, train any of our replacement workers we would have had. So definitely a lot of strategies we learned from 2022 that we would have utilized in 2025. But fortunate for us, we did not have a work stoppage in 2025.
Just with the time remaining, I'm going to open it up for questions for everybody. And if it's okay, I'm going to go ahead and kick that off for kind of all three of you, if you have something you want to contribute to this. But gosh, I just blanked. We found all of you spoke to how important leadership is in all of this. And just, can you give us some insight to back then, were your nursing physician leadership, rest of the hospital leadership informed on disaster preparedness, or were they still, a lot of places were young at that time and learning about it? Was there immediate, just disaster preparedness, hospital incident command system training that needed to happen as you were dealing with all these things?
Happy to talk about my experience. There's a disconnect often between the clinical experts and some of the like EOC responses. I found the people trained in EOC kinds of stuff recognize very quickly that you kind of need to change what you're doing. People that are used to sort of being the clinical leaders day to day will often sort of turn everything into regular clinical leadership workflow and decision making, which obviously is what the EOC is about changing. So there was definitely a period of kind of re-educating people and pushing a little bit and having a couple key champions for that who understand both the clinical implications and the nuts and bolts of the EOC and how to get things done was really key. We started just bringing proposals to EOC in SBAR format that the clinical leaders were used to seeing, and getting them in front of everybody. And it was interesting because once we did that, they were almost, I can't think of one that wasn't approved. So that ended up working for us. One other point I think about leadership that's really important is the amount of moral distress surrounding this is huge. I mean, this was not a school shooting or some other event that you would automatically expect to have a lot of distress associated with it, but the distress people felt at not knowing whether we could take care of all the patients was huge. I had multiple nursing leaders come up to me at different points in time and say, we got to stop accepting all these patients. And I said, I'm sorry, we can't. There are people who no longer work in some of our units as a result of this surge response. And I feel some level of personal responsibility for that as somebody who didn't let us take our foot off the gas in the middle of this. So it is, everything we did, I feel like I can stand behind and say we did this for the right reasons. But changing ratios as an example, there are a lot of people who are a good ICU nurse in a lot of ways is somebody who's not willing to relax their standards, right? Who 10 people say this is okay and they say no, this is actually not okay and here's why. And this was a situation where we really forced them in some ways to abandon some of that, and that definitely carried some long-term consequences with it.
Yeah, to the point about the moral distress, I think it's hard, and particularly when events that are morally distressful were happening in such rapid succession during between 2020 and 2023 and 2024, and are sort of escalating now for like non-clinical reasons. And so it's incredibly difficult to do it. I think what helped us was developing a communication strategy that showed that humans were running this, and not suits with bank accounts. And rather than sending emails with talking points and referring to wellness resources, actually having in-person town halls, and having our CEO and other clinical leaders there, and reminding of the mission, acknowledging distress, and following up with like real solutions, and doing things that they could. I mean, you made it very clear, like during the multi-demic, I think what was hard about that is that everybody was in that situation. And so when some of the solutions that would come, like, well, why can't we just call in the the federal resources and deployable assets to our state? It's like, well, everybody's dealing with this. And so acknowledging that that's not a solution, and being very honest about that, but reminding them that that the alternative of not taking care of kids is literally kids dying. And so entertaining actual strategies that will help and offset. And I think we learned very quickly that offering financial incentives will only go so far, and so you have to follow through with some creative resources. And so I think that helped us address the moral distress. Wasn't perfect, but I think it did help.
Yeah, for us, I think the bigger moral distress was a work stoppage of 2022, and then what we utilized from there, going into RSV surge, with just increased transparency from leadership doing things that they wouldn't ask their staff not to do. We also learned how to be, from a nursing perspective, to be better communicators with our providers, because that was a huge gap from 2022 work stoppage. So then how do we keep things secret but still share, right? And that was one of the learning points from our 2022 that we then carried over to RSV surge, to our 2025 negotiations. But the bigger moral distress was 2022. And then the COVID one, when do you use an N95? Do you not use an N95? Those are the two bigger moral distress ones than RSV surge, because to the point, it's just they're pediatric patients. It is my belief that those in pediatrics are, understand the importance that these are the kids that we need to take care of. and there's nowhere for them to go.
I think one of about the whole involvement of individuals in solutions and with the emergency response, I think we learned a lot from COVID, where we would try to use incident command to solve problems, particularly operational issues, and we deviated from our incident command structure significantly just to include more ideas and more operational leaders in those discussions. And you'd quickly have an incident command meeting with 60 individuals, and you'd have people invariably commenting on stuff that they have no business commenting on because it's something completely out of their area of expertise. And so in subsequent crises, what we've done is stuck to a really small incident command structure, but been very aggressive about setting up operational work groups, like nest that within our incident command structure. And so if we have an operational problem that it's where a small incident command team is not going to resolve, we assign a section chief to a specific operational work group. And then that's where you bring in the correct people and the operational leaders and make that a larger group where we're getting a lot of informed opinion that incorporates frontline needs with a very specific objective of addressing one operational issue, and then having a well delineated chain of communication back into incident command where those problems can be reported, and then the incident command structure can deploy resources to address the strategy that they've developed. And that's helped us maintain a small, tight incident command structure without alienating the people that can really solve problems and give us the most informed feedback on how we're doing.
Thanks. So can I just highlight that work group concept? We did that during the pandemic and tridemic afterwards, and inadvertently, but it worked really well. And, just want to highlight that. I want to call out if Lindsay, if you're okay to come off of mute. You have a couple of comments and a question that I wanted you to be able to speak to if you're able to.
Thanks. Well, my question was actually for Carl or Dr. Erickson, I apologize. And I know you had a lot of learnings based on your RSV surge. And I know that the Oregon Health Authority, the HPO that we fall under here in our region, they wrote a pediatric surge plan for our region. And my question to you directly was, did the plan that you guys implemented, did you use that surge plan as a template, or was it vice versa? Did you end up informing that surge plan afterwards of all of the changes that you made and the things that you guys did? Because right now that pediatric surge plan, which I believe was written and published in 2019 off the top of my head, it's informing the region, all of Portland area, of how we would do a pediatric surge. And so I'm questioning if that helped inform it. And then my other comment was commenting on the template that was referred to for work stoppage. And within Providence, we have a large system that kind of stepped in when we started with our multi-hospital strike, and they stepped in with a template, and we really came in and kind of obliterated just because we went from one hospital striking with 1,000 nurses to 8 hospitals striking with 5,000 nurses plus physicians, which was unprecedented at that point. So we lost OBGYN practitioners along with hospitalists. And so we kind of blew that template out of the water and said, great, thanks, we really appreciate it, but this is what we're going to have to do from this point on.
Thanks, Lindsay. Please call me Carl. Yeah, the same sort of strategy that underlined that, or that was the blueprint for the HPO pediatric surge document was the strategy that we used. So we'd gotten together back in like 2016 to 2018 or so to do some pediatric surge planning. And it was this wasn't really about the individual organizations so much. It was more about how we coordinated between the different hospitals. And what I really love about it is for everybody here who's based in a children's hospital, for everybody, I guess, it emphasized the role of the non-children's hospital. Because I think often what happens is the children's hospitals see themselves as having to kind of bear this on their own. And I think, depending on what the landscape looks like, the children's hospitals may be taking care of the vast majority of hospitalized kids in your area. But there is no way we could have done this just with the children's hospitals. We absolutely relied on the response of the non-children's hospitals, both in acute care and in the NICU. And if you look at those numbers and you try to figure out what it would have looked like for us to try to take those patients as well, it would have been a dramatically different response for us. So what I really like about that plan is it kind of highlights that everybody, you know, plays a role in this, that piece of it, I think, ended up being really valuable in our response.
Thank you. That the community, whether they're children's or non-children's hospitals in whatever context, are so important to all disasters. But yes, that one, it highlighted that. Can I call on Stephanie Al-Hassani, if you are able to come off of mute? And you made a comment about paramedics, I think is really important for everybody to hear too.
Yeah, I think I'm at Rainbow in Cleveland, and we are utilized a lot in ED. I help with a lot of our disaster preparations and response. But I think a lot of times hospitals, both children's and adults, don't utilize paramedics on a day-to-day basis within their scope of practices, even in an emergency. I know during COVID, I was very frustrated with a lot of things, as everyone was, because we weren't utilized, and you would hear about places needing help, but we couldn't go to help them. And it was all things that we can do that are in our scope of practice, but our hospitals don't allow. So I just always like to remind everyone that we're there. We can do a lot of nursing tasks. We can do a lot of respiratory therapy tasks, and on a day-to-day basis, but especially during an emergency, I think it's one of those things that we can talk to upper leadership about letting us do things. Where I work, I cannot do high flow. I cannot do a lot of things, but within my state scope of practice, I am allowed. It's just the hospital doesn't allow. So if we're in those situations, maybe it needs to be looked at that paramedics can definitely step up and help.
Yeah, definitely like a kind of a state level and higher things that system that needs to be put in place. I think it's a great thing to think of as an additional source for staffing. We have, I'm gonna give 5 more minutes. Please, if anybody has any questions or has any unique ways that they've used staff in either a surge or a staff shortage, we would love to hear about it. If you have templates, please, if you are able to share them, I think that would be useful for everybody.
Can I just make a comment? I remember hearing about this, like, I think it was during the multi-demic, I think. But it was at Cincinnati Children's, and I know Nate's on, and I hate to speak for him or put him on the spot, but I was told about this. It was sort of a where they had Cincinnati Gives Back or something. It was something like that, where staff who oftentimes worked in non-clinical areas, but felt very tied to the clinical mission of the organization, were offered the opportunity to sort of serve in sort of a volunteer role. And many people had chosen perhaps to be like runners or some other support staff. And I see they came off camera, so I apologize for putting you on the spot. As I started speaking, I saw your name in the cascade. So thanks for commenting.
No, thanks, Larry, for bringing it up. Yeah, the term is now, or the phrase is now called One Cincinnati. And so it's been activated a number of times for that kind of request. And the times that it's been used is when our tube system goes down. So the system that's used to send medications, labs, everything else. And you just think about the sheer number in the system that would be required and just the sheer volume of people that's needed for that. And that is sort of the it's an infrequent event, but that has sort of been one of those examples that we've been able to use that activation. And it's an email that goes out to all the employees. They can sign up, and then they sign up for specific times, and then they can contribute that way. So thanks for that call out, Larry. Appreciate it.
And Nate, the tube system going down is not always an infrequent event, definitely from place to place. So that's definitely helpful to I wanted to just, while if anyone has, please come off mute and go ahead and speak. But I wanted to bring up that thank you, Julie, for putting in the comments that the evacuation focus session is at 2:30, and they're talking about psychological safety of staff. We'll be talking about that in a later session as well. But please, if you would like to go ahead and join, you can. The link is there below that as well. You can click on and register.
I have one tactic that we used during an anesthesia shortage when we lost our anesthesia providers, got kind of dwindled down actually. So one of the tactics that we did is, and I'm going to mess this up, I'm not clinical, but we really started to reevaluate within, nursing staffing priorities and everything else. What could be done at the ED level versus the OR level? Things that used to be done in the ED, for small procedures that used to be done in the ED, they got shifted to the OR. Or at least shifted to a procedure level where they needed full anesthesia support. And so looking back and saying who is competency to do these procedures, what are our capabilities to do these things, and really kind of reevaluating what can be done in the ED versus what had to be done in the OR. And so starting kind of piecelining some of that out. I know that's not the best during surge, but when you're looking at staffing, some of those staffing snafus where we don't have a particular type of staff, for us, it was anesthesia providers. So that was all general cases, and we really had kind of focus on critical, obviously, urgent, emergent, critical cases, and what can be done in the ED under different levels of guidelines.
Yeah, I think it goes both ways. If the ED is facing a surge, then the OR kind of taking some of those roles off if they have the staffing for it. So thank you, Lindsay. I think there's so much variability in what emergency departments sedate for across the country, especially in pediatrics. I'm gonna do, I'm supposed to count to 10, so let me give other people a chance to speak up about interesting ways that they've staffed or questions that they have. I do have one last question for you guys. Julie, if it's okay if I leave you like 3 minutes, it's 2 minutes, okay. And then one thing I just wanted to say is that, going forward, the country is, the world is not always an easy place to be in. So going forward, we're just gonna, when you pop onto the call, we're gonna start with just a minute and a half of kind of some breathing exercises. So if you hop on while people are getting on, we're just gonna have that playing, and we won't take up anyone's time, but just to get everyone refocused within your crazy life in your hospital and outside. So just expect that with the sessions going forward to help refocus everybody. My last question is for all of you, is there any of you that had staffing changes that you made that, Nate described one of them that turned into One Cincinnati, but that stayed after you went through the surge or otherwise staffing shortage?
I mean, I could comment. It's not a staffing role, but in our incident command structure, they have FEMA calls out the the safety officer, and it's designed where that's sort of physical hazards, environmental health and safety. That's the intent. And so what we did with the success we had with our Center for Quality and Safety is that our senior director of quality and safety is now sort of serves as a co-safety officer with our physical safety officer with the hospital, and provides a patient safety focused perspective to every incident that we activate for. So we find value in that.
I like that. Carl, you had a similar role, a safety role in medical management too during your crisis. So that sounds like a really useful role to continue to keep in the incident command system. Anyone else? I know it's it feels like a Monday, so that's why we didn't do breakouts today. Please definitely give your feedback about this panel, and you know, if you enjoyed the panels, if you want to have more panels in the future, we would love to do them as well. Really great and glad to have all of you here today.
Few last minute updates. Our upcoming DRC sessions will meet with the surge capacity session next month on October 7th, same time, same place. Literally, it is the same Zoom link that you used for this month. So as I do reoccurring meetings in Zoom, I can do it for 2 months in a row. But because of that full collaborative session in November, that's why you're getting only 2 at a time. So October will be the same time, same place, same link as today. And then November will also have the full collaborative session. Here is your continuing education information. You can claim credit by texting VEFCAX to that number, or you can go to the Pediatric Pandemic Network.org code website there. And these again will be posted online as well, so you can get that. So while you are completing your session evaluation, I'll put those in the chat. But keep in mind that if you don't have time to finish this session evaluation right now, you can just keep it up and log off this call and go to your next one and then come back to that later on. So let me put... Here's the session evaluation link. Here's the CE credit for you as well. And whenever you're ready, you can go ahead and log off. Thank you all for being here today, and we will see you October 7th.